Let me introduce you guys to Mark Roberts from University of Pittsburgh, who does like very, very detailed modeling of epidemiology. If you go to their website, you see really cool models of measles and diseases like that, where they look at, individual like, schools and, people. And now they've been applying their work to COVID-19. So Mark, love to hear what you have to say.
Okay, well, thank you. Well, first, I have no financial conflicts of interest, which is unfortunate. I think it would be great to have some, but I don't have any. I'm an unpaid member of the technical advisory board of a company called Epidemic, which the University of Pittsburgh built last year to try to commercialize some of our agent-based modeling tools. But I have no other interest, I have no role in that other than being on their advisory board. So what I was going to talk about today was I'm going to introduce you to FRED, our agent-based modeling tool, and some recent use cases of FRED in influenza and measles, a little bit about how we've been converting our FRED modeling tool into a generic programming environment to make it easier to use. You had to be a pretty good C++ programmer to use it before, and we've been trying to make it much, much more generic and easy to use from the outside. And then I'm going to go through how we've been modeling the COVID-19 problem. So FRED is called the Framework for Reconstructing Epidemic Dynamics. And this is the history of, it's about a 15-year history of funding from different organizations. Our major source of funding was, we were a center of excellence for the MIDAS program, the Modeling Infectious Disease Agent Study, back since 2009. We've been funded by the Robert Wood Johnson Foundation, by the Bill and Melinda Gates Foundation, and by the Venter Foundation. We've also had other small grants from some other foundations. We have been specializing at the Public Health Dynamics Lab in agent-based modeling, and agent-based models represent individual people along with all their social contacts and interactions with the environment. We can include individual behavioral responses to things in the agents, and we can investigate the interactions between things that are distributed spatially, such as healthcare facilities and other things. We also, because it's an agent-based simulation model, it has the ability to understand the emergent properties of the sum total of the actions of individuals in their environment. And we can also overlay on the model the impact of policies and programs. The real reason it's called FRED, though, for those of you who know anything about Pittsburgh, FRED is where Mr. Rogers' neighborhood started. And it was Fred McFeely Rogers who was all about neighborhoods. And since this is all about locations, Don Burke, our dean, said we should name it FRED after Fred Rogers. This is just a schematic of how FRED works. Its fundamental core is a synthetic population in the United States, which I'll talk about more in a minute. Each person in the synthetic population can have a series of health conditions that represent diseases or represent other activities. Each individual can have behavior models, things like choosing to stay home from work, or choosing to not send your kids to school, or choosing to get vaccinated or not choosing to get vaccinated. We can put policies and procedures like closing schools or social distancing or things like that on top of those models, and then we can start each model with initial conditions. It has a fairly complicated simulation engine that can run visualizations and run the day by day. The model can run at hour-by-hour levels, but we normally run it day by day. And then if you're running it on the entire United States, you're running a 350 million agent-based simulation model, so it takes a really large cluster or the Pittsburgh supercomputer. But if you run it on just a state or a county, it can run very easily on a single machine. This is a graphic of what we think is the core foundation of FRED. It's a census-matched synthetic population, which takes data from the U.S. Census and constructs a synthetic population within each census block. And a census block is slightly smaller than a census tract. And at the census block level, the synthetic people in our population have exactly the same statistical properties as the real people in that census block, but you can't find you in your census tract. So any table that you make of the synthetic people, age by income, income by household size by race, those are all equivalent to the real census block, but the people themselves are artificial. We also have from the Department of Education the location and size of every school in the United States. We have from the Bureau of Labor Statistics the location and size of every employment center in each census tract. The way the population was created was using a technique from the census department called iterative proportional fitting. And what it really does is it takes the table marginals of the 5 major demographic characteristics: age, gender, household size, household income, and race, and constructs synthetic data such that all the table marginals in any small geographic region called the census block are identical to those table margins in the real census tract, but the internal cells are not identical. Excuse me, I'm sorry. This just shows, this is for Allegheny County where Pittsburgh is. This shows the household size, the age, the race, the income, and it tracks perfectly what the actual census data is in that. And it does also track if you do household size by income or race by age. All those things are accurate. So the way Fred works day by day, so we have the location and size of every school, the location and size of every workplace. We have households. Here I'm showing just 2 households. One has 2 adults and 2 children. The other has 2 adults and 1 child. The guy in red there, let's say he just got influenza. He wakes up. The parents, some of the parents go to work. All the kids go to school, although we do have a certain portion of kids who are homeschooled based on the rates in each state. They mix with other people in their school, they mix with other people in their work, and they go home in the afternoon, and now they can infect the people who got infected, can infect other people. They also contact people in their neighborhood. So every household is located in a physical location, and we have a neighborhood size, which is directed around that household location, and people contact each other in their own neighborhoods as well. Now, the thing that's useful about this, we think, is that we can overlay on top of this synthetic population, which is geospatially accurate to the population of the United States at any given location. We can overlay health conditions, we can overlay climate, we can overlay community resources, we've done stuff on excess cardiovascular mortality, we've done all kinds of things because you can use the model to geospatially link lots of things that come from different data sets. The first work that we did was in the late 2000s was modeling the spread of the 2008-2009 H1N1 epidemic spread. And I think you should see, this is a model of the entire United States. And what you're seeing is the red is people who have, if you dropped a couple of cases of H1N1 into the United States, which had no immunity to H1N1 at the time, and you would watch it spread to the United States, and then you would watch people recover. There is a sort of a modified gravity model that has the number of people who go between Chicago and LA every day, and between LA and Seattle every day, and stuff like that. We don't get that data directly from the FAA or from other places, but we could have. We just didn't. We also used in the 2008-2009, we could run various different scenarios about what happens if you restrict travel, what happens if you have different targeted policies of quarantining, treating, and quarantining, or both, and we showed the potential reductions in various different with various different combinations of interventions. And we had posted a faculty member. We had faculty members from the Public Health Dynamics Lab down with the Assistant Secretary of Public Health Preparedness in DC during the H1N1 epidemic, and they would go to the morning situation meetings, send back questions about what would happen if we did X. We'd run it in the models and then talk about it the next day. This just shows some work we did for them about prioritizing different groups of people to be vaccinated once you actually had limited amounts of vaccine available. So we could do all kinds of those what-if scenarios. A much more recent example of what we've done is what we've done in the measles epidemic, and this was prompted by the resurgence of measles in the public media after the Disneyland outbreak of 2014-2015. And this is an excellent example of why we need lots of people to work on these things, because the person who founded the Public Health Dynamics Laboratory, Don Burke, said we should make a simulation model of measles because people have to understand how important herd immunity is. And my response was, everybody understands herd immunity. That's not going to help anybody. And he ignored me, which was a good thing. And we built the measles simulator. And it's important to remember that measles spreads relatively similarly to most other infectious diseases that spread by contact, but it's remarkably infectious. the way you describe the infectiousness of a disease agent is by what's called its R naught, or its basic reproductive number, which is on average, if you had a population that had no immunity to a disease and you dropped a case of that disease into that community with no immunity and no protection, how many people would that person be expected to infect on average? And measles is one of the most infectious diseases there are. It has an R naught of 16 to 18. Regular human influenza has an R naught of only 0.9 to 2.1, so it's markedly infectious. And then, so what we first built was a simple simulation that made some pretty stupid assumptions, but it was made just for a demonstration. So somebody give me a state. Actually, I think Greg's the only person who can speak. I think everybody else is on mute.
Oh, say again?
Just give me a state. Pick a state.
Oh, let's do California. Let's see how badly we're going to be doing.
All right, and then you have to select a city. Should we do Oakland?
Cool.
And then what you will see on the left-hand side of the screen is you'll see what would happen in Alameda County, which is where Oakland is, if only 80% of children who should be vaccinated against measles were vaccinated, and you drop a random case of measles into Alameda County schools. On the right, you see the exact same introduction, but if 95% of the children who should be vaccinated against measles are. And what you see is you get hundreds and hundreds of cases if only 80% of the kids are, and you get almost no cases if 95%. So this was used as a description of the importance of herd immunity. Now, to be fair, it's not exactly that. What we do is we ran 100 simulations for each introduction, calculated the mean number of cases over those 100 introductions, and we're showing you a movie of the mean number of cases. So it could be worse than that, but it could be better than that. So this is some evidence of the impact that we had. Interestingly enough, the 538.com wrote a thing about us, and they also had picked up that there's a physician out in California, Senator Richard Pan, who happens to be he's a state senator, but he's also a doctor. And he happens to be a University of Pittsburgh medical school graduate. And he saw a link to the Fred Measles app on an alumni blog. And he took it around to a bunch of different senators of his colleagues and said, look, this is your county at 80% and your county at 95%. And then there was we got in Modern Healthcare, there was a quote from the Senator Marty Block, who was one of Senator Pan's colleagues, who said it was the Pitt simulation that changed his mind to vote for reducing exemptions to measles. So our belief is that we're trying to build tools that can be used by policymakers to help make their decisions. Now, the original measles simulation had a fairly silly assumption. It said that all of the schools in your county are either at 80% or all of the schools are at 95%, and assumed a uniform vaccination rate within all schools. And we just know that's not true. And in fact, we got asked by the American Academy of Pediatrics in conjunction with some people in Texas to run, they had publicly available data of the actual vaccination rates in schools and districts in Texas. And this is the distribution of all the number. There were 164 schools in the state of Texas that had vaccination rates well below 95%. In fact, there was one that had a vaccination rate only in the 40% range. And so we used the actual vaccination rate of the actual schools, and we constructed simulations of Texas, and we called things a little bit differently. We said there are people who are refusers, people who are innocent bystanders. And innocent bystanders are the people who, because in measles, there's a few people who can't be vaccinated. A few kids, because of a disease they have, or because they're too young, they're under a year old, they can't be vaccinated, or they have a disease that doesn't allow them to be vaccinated, or there's a very small group of people who the vaccine just won't take. It won't produce enough immune response. And that's about 3 to 4% of the population who either can't be vaccinated or the vaccine won't work. So we decided in districts where there were more than 5% of the people who were not vaccinated, we called the people over 5% refusers, meaning they just simply didn't want to be vaccinated. And we then did this by MSA rather than by county. We also did it by county. You can I won't go here again because it's too hard to, but if you want to use, you can go look at Texas. And we did also now, we have school and district-specific data for Pennsylvania and for Florida. We wrote a paper about this in JAMA Network Open that describes how the size of measles outbreaks varies across these kinds of vaccination. Now, the other thing that we've been spending a lot of time on in the last couple of years doing is converting two things in Fred. One is we wanted the population, which had been a static population, to become dynamic, meaning the people can age, they can get diseases, they can have a much longer term history, and that we call Fred ages and staging. And that also incorporates population growth, migration, and things like that, and will, when we get a little bit more time to work on it, social networks as well as just proximity. And we needed the ability to define new diseases relatively easily, and you didn't have to be a crackerjack C++ programmer to be able to encode new diseases. And we spent a lot of time on that, and we now have a generic condition structure that allows you to make any condition you want, and it's we are developing even a web front end where you can just pick and choose things. So if you wanted something to be, if you wanted to model HIV disease, you could model HIV disease, and each person with HIV disease not only could have states of that disease, but could have variables that describe that disease, like CD4 count, viral load, those kinds of things. And then you can transition between states, and you can have all kinds of states. You can make, excuse me, let me let my dog out, he's barking. Sorry. Problems of COVID isolation. So you can do demographic conditions, health-related conditions, social conditions, infectious diseases, non-infectious diseases. We've been able to make all kinds of different structures. You can see that basically you can make any Markovian-like or state transition model you want with as many states as you want, and those states can have both transition probabilities and durations. And for every condition, every agent has a current state, and you can only be in at least in only one state at the time, and you can only make one transition each iteration. There's a transition matrix, it can be relatively complicated, that describes the transitions between states, and you describe also a duration within a state, and that's stochastically. So now I'm going to progress to see what we've been doing about COVID-19. The most important thing, I think, currently to remember about COVID-19 or to know about COVID-19 is there's a very large number of uncertainties in the characteristics of the virus and how the disease operates. We've tried to do our best to compile data from China, Italy, the CDC, and early results from New York to obtain the best parameter estimates we can for the various different things that matter in modeling. One is the infectivity, that R naught, the basic reproductive number. That ranges from a low of 1.7, 1.8 up to as high as 3. In some estimates, we believe it's more like 1.8. The rate of developing symptoms if you get infected. If you get infected and develop symptoms, what's the rate of requiring hospitalization? Once you're in the hospital, what's the rate you require an ICU? And what's the rate you require a ventilator? And what's the rate at which you die? This is the basic state transition model for our COVID model that exists in any agent in our simulation who has the disease. There are susceptibles who do not have the disease. If they contact somebody who has the disease, they have some probability of getting infected, and the infectivity times the contact rate times the duration, we can tune to be whatever R naught we want, and we currently have run the model in an R naught of 1.7 and sometimes 2.2, because there have been some people who have wanted to see what it looks like with a higher infection rate. Once you're infected, you have a latent infection for a few days where you're infected, but you are not yet infectious. That's about 2 days with a distribution around it. We use a log normal distribution for that. Once you become infectious, you're infectious for several days before you become symptomatic. And we have 3 days for that with a distribution around it. Once you become symptomatic, you can either become severely symptomatic or mildly symptomatic. And if you're severely symptomatic, you can require hospitalization. Once you're in the hospital, you can require going to the ICU. Once you're in the ICU, you can require a ventilator. And from any of those, either on a ventilator in the ICU or in the hospital, you can die. And all of those transitions, once you become symptomatic, are all age dependent. They are more severe if you're older than if you're younger.
So are all those estimated from data or inferred somehow?
They're all estimated from existing data on hospitalization rates, ICUs, and ventilator use in Italy, New York City, Washington State, and a lot of this comes directly from the CDC's current data. What's harder is a little bit upstream from that, because we really don't have any good prevalence data yet to know how many people are actually not infectious and completely asymptomatic, and then completely asymptomatic and then infectious, because there have been no prevalence studies. The only people who are getting tested in the United States are people who are sick or have some reason to get tested. So we have more uncertainty in how many people don't get symptomatic at all.
So have you done parameter sweeps, or maybe you're about to talk about it, to see how sensitive results are to those details?
Sort of. We've done it. It's harder to do parameter sweeps in an agent-based simulation model than it is in any kinds of equation models, because it takes actually a fairly long time to run the models computationally. You know, it takes, and if you want to do a real efficient calibration routine where you run a lot of the uncertain parameters across multiple different levels at multiple different combinations, it just takes a lot of computational power. We've been doing sensitivity analyses of the various different things that we're very uncertain about, and then trying to adjust those to match what the early phases of the epidemic have looked like in the United States. That answer the question?
Yes. And then if you were, so you said that a whole US model would be 300 million agents. Is that actually required? Can you give the ability to group 100 people into one agent? Not losing accuracy?
We don't have that ability.
Okay.
It's not, people have talked about that there's no reason that you have to model every single individual. We've had a bunch of debates about that. We had an interesting grant from DARPA to the computer science department here, and we joined them to sort of see whether or not you could duplicate the results of an agent-based simulation model in just the appropriately constructed Bayesian network. And for many things you can, but remember that the thing about interactive models is that they have emergent properties, and emergent properties are hard to observe. They're hard to predict if you didn't observe them in the runs that you did to calibrate the Bayesian model. So we've been debating that back and forth. But you can make emulators of these models, and the emulators work most of the time surprisingly well. So if we've done a model in Fred of the opioid use disorder, and it's very complicated. And so we've run 10, 20,000 iterations with changes in inputs and changes in outputs, and then we've made equation-based data mine emulators of the simulation to do better calibration fitting with less computational power. So here's the other parameters that we've been using. We have an R naught in this particular, it's actually 1.7 now, it was 1.8. These are the likelihood of hospitalization if you get the disease, and the likelihood of transferring to the ICU. Once you're in the ICU, the likelihood of requiring a ventilator, and once you're on a ventilator, the likelihood you would die. So this is what the output of the model looks like. This is a terrifying picture. This is what would happen in the state of Pennsylvania in terms of hospitalizations, ICUs, ventilators, and deaths if you don't do any, so if we didn't do anything, we didn't do any social distancing, we didn't do anything at all, and just allow the epidemic to run its course. And our estimates are you'd have a little bit over 250,000 hospitalizations with as many as 50,000 deaths if you didn't do anything, if you just let the disease take place. What we have also done, we can put in what we call social distancing, and this graph just shows how we represent social distancing in our simulation model. Now, it's not perfect, but because there's only 3 places people contact each other in our model. They contact each other in their households and neighborhoods, at school, and at work. And that's the only places they touch each other. And so the way our social distancing works is we have a intensity and a duration. And the intensity is, like here this says 70% for 4 weeks. And what that means is that 70% of the people who would normally go to work don't go to work, and those same 70% of people don't mingle in their neighborhood. And then schools are different. You either have schools open or schools closed. And in our simulations, because in Pennsylvania, every schools were closed, have been closed for a long time, schools are always closed. So here you see an example of social distancing that starts at 70%, after a month goes down to 60%, and then goes down to 50% for 2 weeks. And we've done lots of different examples of different kinds of social distancing. This is what would happen in the state of Pennsylvania if you only did social distancing for 4 weeks, which was the original intent to open up the economy by Easter again. And our estimates are that if you do it for 4 weeks and then take it down to 0, you'll still get 250,000 hospitalizations as the epidemic takes place after you release social distancing. But if you keep social distancing on for longer, here's another example. The little graph at the bottom is how long you keep a certain amount of social distancing. You can delay and lower the peak substantially, and that is a good thing. However, lots of things still matter. So for example, this is just a quick sensitivity analysis over the likelihood of requiring hospitalization based on different assumptions about how likely you are to get symptoms, how likely you are to require hospitalization if you get sick. And the original data coming out of China and Italy said it was about 20%, although when in the United States, the original CDC data had that pegged at about 20%. But if you look at the early data from New York City, the early data from Washington and a couple of other places, it looked like it was quite a bit lower than that. And that the rate of requirement, there's actually getting more and more data that a lot of people who get the disease are completely asymptomatic. And we've now been using a 9 or 10% rate of requiring hospitalization if you get the disease, which is substantially lower than the original data from the CDC.
Wait, so the difference is the number of people that we thought were infected. Now we believe there are more people who are infected but asymptomatic?
Right. This is the number. This is if you get the disease, what's your likelihood of requiring going to the hospital? And originally, the CDC felt that number was about 20%. Of if you got the disease, 20% of the people who got the disease would get so sick they would have to require hospitalization. Most of us believe that number is a lot less than that now. And part of the reason it's probably smaller than that is because we don't have the denominator right. Because we're not testing. We're not testing randomly. We're not doing a prevalence study yet. It's all the people who get tested are people who got currently in the United States are getting tested for a reason, have a symptom or something like that, and they may have. So it's not really a very good prevalence estimate. But from the work that we've been doing in Allegheny County with our public health department, our own personal best guess is that it's somewhere around 10%, although that varies by the age of the individual. Hold on one sec.
No, it makes perfect sense. Cool.
Sorry, I had to adjust for my 2.5-year-old granddaughter here. Sorry. So anyway, the goal here is only that we're showing that the rate of disease that requires hospitalization matters a lot, and we don't have a very hard estimate of that number. The other thing that's important is here we just showed, you get these huge, this is in Pittsburgh alone, and this is just showing what happens if you, again, shut off social distancing completely. But what we can do is we can show you that as you continue to extend that, you lower the peak and delay the peak. And both of those things are important. As you delay the peak, you affect the ability of the healthcare system to be able to prepare and get PPE done and all that sort of stuff. And if you lower the peak, you can make the peak go below the capacities of your healthcare system. And here's another example. This is actually the entire state of Pennsylvania run. If you never turn off social distancing, we turn it on a little bit those first couple of weeks because we don't think, this is our best guess, we don't think people did very good social distancing early on in the epidemic. Then people have gotten a lot better at it for the last 3 or 4 weeks. And then if you even just dialed it down to 50% for the whole rest of the year, and then you would go from 100,000 hospitalizations down to 10,600 hospitalizations by and you would delay the peak much longer. And there's a bunch of other things that we have been thinking about putting in, that we have put in, and we can either turn on or turn off. One of them is most of the other coronaviruses have what is called seasonal forcing, and so does influenza. That means the disease is much more transmitted and is much more able to be infectious in the winter and fall than it is in the summer. You know, we don't get much flu in the summer. We get flu in the fall and winter, or winter and early spring. And the same is true of all the endemic coronaviruses. There are 4 endemic coronaviruses in the United States that kids pass back and forth all the time, and they have a very strong seasonality. So we can build that in. In these models, it is currently not. We turned it off because we don't really know yet how much seasonality or seasonal forcing there really is in this particular strain of coronavirus. But the evidence that there is seasonal forcing comes primarily from the fact that if you look at where it is in the world, it's been much more prevalent and much more deadly in temperate climates than in tropical climates. And so that would be some indication that there is seasonal variation. And so we can put that in, and it's usually sort of modeled as a sinusoidal curve that has some maximum sometime in the fall, winter, and a minimum sometime in the summer. We can turn that on. There's lots of things like that we can do in the modeling to sort of understand what matches best with reality. So our conclusions about COVID-19 are that social distancing is really important, that the more adequate social distancing is, it delays the peak and lowers the peak. We happen to believe, although there are people who disagree with this, that any near-term discontinuation of social distancing allows the epidemic to return. And when you think about any disease for which you don't have immunity to, that eventually the disease will burn out because you will get what turns out to be herd immunity for that disease. And if you have a disease that's not very infectious, you get herd immunity somewhere around 50 or 60% of the people, but you still, if 50 or 60% of the people is still a huge number of people. So for Pennsylvania, if you really believe you need 50% of the people to be infected before you get herd immunity so that one episode won't continue to propagate, there are 14 million people in Pennsylvania, and if you need about 50% of them to be infected and recovered, that's 7 million people. If the case fatality rate's only 1%, that's still 70,000 deaths. That's still an unacceptable number of deaths for a state. So we have used these models to believe that you do need to continue social distancing. However, the other thing that we think you can use these models for is understand what's the right mechanism by which you release social distancing. So for example, you could say, as now that the FDA has approved a serum antibody test, maybe you release social distancing by doing screening for people who have antibodies. And so if you're one of those people who got asymptomatically infected 3 or 4 weeks ago, and now you have antibodies and you're not sick, you could go back to work because you're not going to spread it to anybody. You can't get it again. We believe that you can't get it again acutely. There is some evidence that people can get coronaviruses many years later, but there may be waning immunity over a long period of time. But the very strong belief by most immunologists is that if you get COVID-19 and you recover and you have antibodies, you won't be reinfected acutely. So there's all kinds of ways we could think about different ways of releasing the social distancing to effectively begin to bring the economy back and get people back to work and things like that, that could be done in a safe way where you could allow people back to work who were not at risk, or you could protect more vigorously the people who were at risk, like the elderly or people with comorbidities. So I think, this is just our scientific team who's been working on this. We don't have a very big team working on this, but Don Burke is the emeritus dean of the school. He's an infectious disease physician who's worked in infectious diseases for 40 some odd years. He founded the Public Health Dynamics Lab and was the instigator of building FRED. And then John Greffenstadt was a computer scientist he's left the university, retired, and he's now a senior scientist for this company that the university made called Epidemic. There's myself, and I'm really a decision scientist as well as an internist, but I mostly do mathematical modeling. And then Mary Crowland is our she's the main. She actually does most of the work in this group of four, and she's has a PhD in epidemiology. Does most of our running of our models and making sure that the model that those of us who the structure of the model is appropriately constructed in thread. And I think that's all. Yeah. So I'd be happy to answer questions. We have not used European data. What we've tried to do is where we have really good data of hospitalizations, ventilators, deaths, New York City, and parts of Pennsylvania. We've tried to run Allegheny County, Philadelphia County, and adjust the parameters so that we see the early takeoff of the rise in cases and the rise in deaths and things like that. And we can adjust parameters to get those pretty well. The right way to do it is, as was noted before, is to really do some version of parameter sweeping of the unknown parameters and really run a lot of simulations. It's a lot easier to do that for a smaller local area like a city or a county than it is for the entire United States. Our hope is, or at least part of our belief is that what we learn about the disease will be true no matter where it is, that the disease won't be any different in Tuscany, Iowa than it is in, Philadelphia. But that the densities and the contact rates and things like that, which the model inherently takes into account, will adjust for those kinds of differences. And the more we can learn about the disease, like I find it hard to believe that somebody who gets symptomatic in Philadelphia and goes into the hospital, that the rate of going to the ICU or the rate of requiring a ventilator or the rate of dying would be that different in different parts of the country. But the contact rates and the age distribution and the comorbidity distributions, those will be different in different parts of the United States.
Hmm. And so the doubling time you get is similar to what is generally observed in different states, or?
Yes. Well, we haven't done a lot of different states. We've been primarily working in Pennsylvania. Mm-hmm. But we could do that, and we could do those tests. And those are tests we've been talking about trying to do to see if we can match those doubling rates and match those hospitalization rates. Where we don't, what you'd like to build the model of a disease, and then just by changing what's different about here and Ohio, or Ohio and Kansas, or Kansas and California, just by the parameters that come from those places being used as the model inputs, if we got the right answer with the same disease model, that would be fantastic. And we haven't done that exactly yet.
Can I ask you a question? You showed earlier, a fairly standard compartmental model, and you were talking about the fact that they're much faster to simulate than an agent-based approach. So I wasn't quite clear what you do there. It basically, if you're running your agent-based simulator, are you saying that each agent itself has a little compartmental model in it, so it can be in one of those 10 different states?
Yeah, each person in the simulation model has a state transition model going in it, which is it's an individual micro-simulation that just says, what state am I in, what are my characteristics, and you move through that. The infection occurs out in the connections that agent has with other people. And that's what's different than a regular SIR compartment model, where the infections all go based on equations and a set of differential equations. Whereas here, the disease progresses, and it doesn't progress necessarily. I mean, you can progress by probability transitions. We can make those be functions of logistic regressions or survival models, or any of the progressions can be as essentially arbitrary. And the disease can be represented as long as you can represent a disease by a series of states and a series of variables that matter, and the transitions between those states and how those states and how those variables change over time. And some of those are relatively simplistic, some are relatively complicated. Then it's the thing that's happened outside and the interactions between the agents that make the transmission of the disease different than the progression of it.
I see, yeah. But I mean, couldn't you, as someone asked this question earlier, but couldn't you just treat an agent as like a population, and then you would get a coarse grained model that would be more similar to like a networked SIR model?
You could. What we worry about is that loses some of the granularity to be able to understand the impact of various different interventions that affect individuals. Mm-hmm. I actually personally think it's a very interesting, debatable point whether or not the detail you get from an agent-based model is actually necessary, or can you? I mean, one of the things we ran one time. This is a while ago. We ran some different models of a model of a particular spread of, I forget what disease it was now, in a city, and we said, let's pretend we only had 1 out of 10 people represented in the model, 1 out of 100, 1 out of, right? Would we get the same answers to the effect of interventions if we were only modeling? And we didn't get the same answers. Now, we may not have done that one correctly, but I think it's a important scientific point about modeling methodology, and is what is the true benefit of actually knowing where and when people are where they're located, what they're doing, and what their interactions are, and how much of that can you represent as a class of people, in
right.
sort of a
do you have a reference on that particular study that you did?
No, we never wrote it up because we thought it was sort of a failed study.
Yeah, I mean,
we should have written it up, but we didn't.
Your findings, basically, you're saying when you work at the coarse grain level, it's like a mean field approximation, and you lose high variance behavior that might affect, you get all kinds of unexpected outcomes that you will lose if you work in the aggregate.
Right, and so another example we did of that was we did years ago. We did a representation of, not in FRED, in just a standard decision analytic microsimulation model. We were simulating the U.S. organ allocation system, and you couldn't just use the average change in laboratories of a group of people, because it's the variance that makes people sicker and makes them more likely or less likely to need a transplant. It's the bound, and so the average numbers didn't work. You had to use the individual trajectory in order to replicate what was happening in the U.S. organ allocation system. And so now I don't know that I have no knowledge whether that's always true or not. And I've become a somewhat more of a convert, I guess. I have a couple of junior faculty members who are very big sort of data mining people who have and the best example was we have this very complicated representation of opioid use disorder that we've been building for the CDC, and Haray Jalal, one of my junior faculty members, he has made an emulator of that simulation tool just by using data mining techniques. We ran the tool thousands of times. We ran the simulation thousands of times, and he has the distribution of inputs and the distribution of outputs, and he did data mining on that, and he's created an emulator that works in about a nanosecond, really fast, that gives us a 0.999 correlation with what the simulation model produces as output. So I'm becoming a little bit more sanguine about that, although I worry sometimes that if
I'm sorry, could you repeat that reference again? You said it was one of your colleagues. I didn't catch his name.
Oh, Haray Jalal.
Okay.
He's not written up our representation of this, but he's done a lot of work on using emulators to represent more complicated simulation models.
So, let me frame it for the context. There's a lot of projects doing like roughly this. You take a very complex, expensive model. Climate is a fantastic example. Yep. You train some approximation, could be polynomial, interpolation, or it could be a neural net. And then you don't trust the neural net. You simply run, you get to run ensembles where you have a few instances of the very expensive model and thousands of the approximations. So you don't really lose the ability to get the higher fidelity, but you get more replicas. There are other techniques that say this is now differential equations, different orders. So you can approximate what's happening within a grid cell using a first degree polynomial, second, third, fourth, and so on. And the higher degree you go, the bendier your approximations become, so you can use bigger grid cells. And that's kind of what we're going for here. We were discussing with Mark. We're going for fewer, coarser agents. We're talking about a first degree approximation with larger grid cells. And obviously you can do things like, which you haven't yet, because that's a notable increase in complexity of implementation, is to have a probability distribution associated with each one of your agents. And then you might get some of the fidelity back from doing coarser runs. So then each agent is going to be more expensive. So there's a lot of things to try.
So the only other thing, and you guys are probably all much more adept at these kinds of techniques than I am, but one of the things that I've always worried about, and maybe it's the clinician part of me or whatever, is that prediction isn't necessarily wisdom. And just because you can predict something doesn't mean you really understand it. And I worry sometimes that the incredible ability to do large database, neural net, or any one of a number of data mining techniques to get predictions can have can ignore the fact that that still may not elucidate mechanisms. And the stupid example I've said about this to a couple of my computer science and Bayesian colleagues is, look, if all you care about is predicting when the sun comes up, it doesn't matter whether you say the Earth goes around the sun or the sun goes around the Earth. You get the same time for the sun to come up. But if you want to fly to the moon, you better get it right. And so I worry sometimes that we would like to believe, and this is an obnoxious statement from somebody with my level of experience to you guys, but we would like to believe that the models we're building of COVID-19 are mechanistic in nature. They're what actually happens in the individual. And we've built models of HIV disease where we build the actual replication of the virus, and it gets mutations, and those mutations make it resistant to the antibiotic you're on, and all. I mean, the model by definition represents the mechanism, whereas some of the data mining techniques that emulate these things don't necessarily help you understand the mechanism. I'll leave it at that.
Can I ask a question that somewhat relates to this? So around, you talked a little bit about computational requirements and the trade-off of kind of the high compute. Can you give more detailed characterization of the computational requirements for the nation scale simulation? Sure. And I have a part two of that also. Sure.
So the problem really for running the entire nation is loading the entire population in RAM so that it doesn't have to page in and out. And to run the United States with a reasonably complicated disease model and a reasonable number of people who get the disease, you need about 1 terabyte of RAM. And we have a couple of nodes here at the Center for Research Computing here at Pitt that have 1 terabyte, and we can run the United States in 30 or 40 minutes on a terabyte node if it's a relatively simple disease. So the trouble is we always like to run multiple runs of the same instantiation to get some fidelity to the answer. You don't want to just take one single answer. We usually take multiple runs. And so it still is, we're still a little bit computationally bound when we're running the entire United States.
Okay, that makes sense. Thanks. And then the follow-up question is, I would imagine that fine-grained location data, like if you had fine-grained, say, GPS tracks of where people were going, has the potential to elucidate a lot of the benefits from the agent-based approach. Can you comment a little bit on what you think that kind of fine-grained mobility information about a population might do? And on this related note to that, can you talk a little bit about the agent synthesis problem and how computationally expensive that part of the problem is? You talked about loading the agents and simulating them, but constructing them or endowing them with rich behavioral information.
So constructing them was only done once. We constructed them from the U.S. Census data using interproportional fitting. So the base population of the United States we did that once. Where it gets a little bit more complicated is if you want to populate that synthetic population with other data about them. So for example, currently the base population only knows the age, the gender, the race, the household size, and the household income of each member of each household. So if you wanted to know, for example, how many people over 65 had chronic obstructive pulmonary disease, we don't have that natively in the model. And what we would have to do is take population data or claims data, which we've done, or other things, and So we did a thing in cardiovascular disease a couple of years ago where 3 of the largest insurance companies in the county gave us the counts of their insurance, people insured by their company, the counts of people who had hypertension, high cholesterol, diabetes, a couple of other things, and the number of people by census tract who had each one of them, who had two of them, and 3 of them, and 4 of them. And they gave us that by age category. So we could, for example, they said in this census tract there are 10 50-year-old females who have diabetes and hypertension. So then we could distribute those diseases across our population to have the real diseases that, and it was about 65% of the population of Allegheny County was covered by those 3 insurers. So we thought we could get a pretty good realistic picture of the cardiovascular risk for each census tract. We can do that statistically pretty easily, and that's not very hard. That goes pretty quickly. It is a little bit harder if you want to make sure that all the N by N tables are right, because you do have to then, you want the marginals to always be right, not just in aggregate, but at finer levels of detail. You do have to do something like iterative proportional fitting or something like that, which is computationally more difficult. But it's still, you only do it once and it's done.
Thank you. And on the topic of location data, how important do you think fine-grained mobility information is in terms of getting higher fidelity agents?
Yeah, I think it could be really important. One of the things that we've been trying to do is there's been a lot of evidence, and in fact there were some articles in the New York Times about using cell tower pinging to understand how many people are really decreasing their mobility. And they showed that there's a tremendous variability in decreasing your mobility across the United States. There's some places where people are staying at home a lot, and there's some places where they're not at all. And we were hoping, when we run the United States models, we were hoping to sort of use that to see whether or not the level of staying at home was related to the level of disease we see in those areas. Because in some sense, that's a representation of the effectiveness of social distancing.
Yeah, thank you.
So then let me ask maybe one final question. How do you validate a model like this? What data do you use?
We don't. No, that was a bad answer. What you try to do, what the best thing to do, we think, is that if you try to find an example of a natural experiment that you didn't control, that you input into the model to see if you get the same answers as the natural experiment that occurred. You can't always do that. We have done that now in some of the measles stuff, because we've been able to track where we say the outbreaks would be given the distribution of vaccination rates, and see where the actual outbreaks of measles have occurred. And we were planning on doing that across a bunch of states that have much more detailed vaccination data for measles and for influenza to represent, if we dial in the influenza vaccination rates, and if we dial in the specific individual measles rates across a whole bunch of different states, does our model predict, at least on average and statistically, does it predict where the outbreaks are and how big they are and those kinds of things? But it is hard to validate these things, because the only way the right way to do it is to find something that happened in real life that you can introduce and see if you get the same answers. A really good example of that, which is not in this particular thing, but in our much larger, a more historic problem that we did where we were modeling the U.S. organ allocation system, there was a change in the rules of how organs were allocated, a very discontinuous change in 2002 that brought in this thing called the MELD score, the model for end-stage liver disease. And prior to that, it had been a very different mechanism for deciding who got organs, and then they introduced this physiologically based MELD score. And we could watch what had been happening we had a physiologic model of end-stage liver disease, and we could say, okay, in 2002, we changed the rules. Do we get the same changes in waiting times, the same changes in death rates, the same changing as they saw in real life? And we did, right? So that gave us confidence that the model represented when we changed what the external rules were, the model predicted the similar kinds of results to what happened in the real world. And that's, I think, the best way to do this.
Thank you very much, Mark. It was just fantastic.
All right. Talk to you later.
All right. Bye-bye.
All right. Thank you.